I ready to invite? So. All right. So I don't know what, let's see here.
Okay.
Yeah, Dr. Jones, what
are you attempting to do?
Well, we're ready to start, so I just want to make sure there's something else happening.
Okay, you can just start, please do.
But what, are people listening?
Yes.
Okay, oh, there you go. So I don't have to
go for it.
Fantastic. Thank you so much for your time, everyone. As I said, we have a deep honor for Dr. Abba Gumel here from behalf of Arizona State University and a series of mathematical credentials that have made me dust off my textbooks and relearn first grade through graduate level mathematics. So just as a personal note, it's been very helpful for my research looking at urban trees, because honestly, trees as lungs is really what kind of helps convince people that both smoking indoors and forest fires outdoors are challenging to trees and people alike. So without further ado, thank you, Doctor. Please, if you have any questions, let me know.
Thank you, Nicholas, for the very nice introduction, and thank you for the invitation to speak. It's a great honor for me to be invited to speak at your seminar series. I wish I could be there in person, but COVID makes it impossible to do so, so it has to be online. But it's a great honor to have the chance to speak with you and share ideas on some of the work that we have been doing on modeling the coronavirus in the United States. So before going into that, I need to acknowledge the funding agencies and also many of my collaborators. I'm sure some I'm not able to mention, but people here, Ibo Inaharu was my former student who is now faculty at Spelman College. Stephen Eikenberry is a colleague here at Arizona State University. He played a major role. Actually, he led the first paper we did on COVID, to mask or not to mask. So he was doing a media interview here. So they took a picture of him wearing a mask in his office. And as Callistus at University of Florida, we've been doing a lot of work together. And this is my grad student, Marina Mancoso, who's also working on COVID and related problems. This is Matthew Scotch at our Biodesign Institute. He's a medical doctor. So, Samantha is my grad student as well, working on this. And I should also acknowledge the working group funded by MSRI. MSRI is the Mathematical Sciences Research Institute out at UC Berkeley. So they hosted a working group at Joint, which is the African Diaspora Joint Meetings for COVID-19. So, and I led that group. Talitha Washington was a member of the group. She was at Howard University, but now moved to Clark Atlanta University. And this is Lawrence Odegwe, who's at Manhattan College, and this Sherry Scott, who's at Milwaukee School of Engineering. And this is, I should not forget Keisha's name, Keisha's Cook at Tulane, and Kamal Bali, a former student of ours who's now at Stony Brook. So anyways, there are quite a number of people who've been involved in the project we've been working on, and I'm sure I did not mention quite a number of others. Anyway, so the purpose of the presentation is to talk about some of the approaches, some of the mathematical modeling approaches used to understand the transmission dynamics of COVID-19 and how to effectively control it. But I'm focusing more on the use of face masks, okay, because this is the main mechanism that we think is most effective so far in the absence of pharmaceutical interventions, okay? But before going into that, I need to give some background. So first, the impact of globalization on public health. So, and I always like to start my lectures with this kind of data to show that diseases have always been around, and there will always be a role for mathematical modelers to try to provide insight into what is going on. So for example, smallpox killed about 300 million people in the 19th century alone. The 1918 pandemic of influenza killed 20 to 50 million people, about 685,000 in the United States. So, and malaria has been very much around. Currently, it's killing about 500,000 people each year, mostly children under the age of 5. And we have the HIV/AIDS epidemic in the 1980s. It's been going on still, so posing serious problems and mortality. We have the first coronavirus in 2002, 2003, the SARS coronavirus, which I'll talk about in some detail later on, and also the second one, MERS, Middle Eastern Respiratory Syndrome. I'll talk about that later as well. Ebola outbreaks, 2014, 2016, in 3 countries in Western Africa, Guinea, Liberia, and Sierra Leone, and so on. And now we have the big one, COVID-19, which as of today has 57 million confirmed cases and over 1.3 million people have already died globally of the disease. So why do we care? Why do we care about what's going on elsewhere? The reason is simply that we're all a flight or 2 away from a serious epidemic. Okay, and that's the main point. This is a quotation when we were modeling the SARS epidemic in Canada. I was at the University of Manitoba in Canada at the time. And the Canada's Advisory Committee on SARS actually came up with this quotation that we constantly a short flight away from a serious epidemic. And the reason this was the case was SARS was brought into Canada by a family who went back to their native Hong Kong for holiday and then came back with the disease, and that's what triggered the epidemic, the SARS epidemic in Canada at the time. So things like that. We're just a few flights away because of globalization to serious. The same thing with COVID-19. It started out in Wuhan, but then it spread into Europe, and from Europe into New York, into the United States, and so on. So people just fly. As long as there's global travel and global trade, we're all vulnerable to what is happening in power places. This is the point I was trying to make. Therefore, if there's an outbreak, and that's why during the Ebola outbreak, the CDC played a major role, the US Army played a major role in controlling the epidemic of Ebola in the 3 countries. The US Army built like 3,000 tents in Liberia, Sierra Leone, and Guinea, which acted as makeshift shelters for isolation and quarantine. So the point is, we're all in this together. If things are happening in faraway places, does not mean we all fold our arms and do nothing, because we're all, again, in this together. All right. So what is the role of mathematical modeling in disease dynamics? There are so many different reasons why people model diseases, but I just list a few of what I think are the key reasons. We model diseases to build and test various theories. Okay, so in times of an epidemic, for example, public health people may have some conjectures, some ideas of what they think is the best way to control the spread of the disease. Okay, so we can use modeling to test all of those. For example, they may say, well, maybe this is a disease that is controllable using basic public health measures. We may not need pharmaceutical intervention. We can check that, just like we did during the SARS epidemic of 2002, 2003. We showed clearly, not just our group, but many other groups have shown that SARS was a disease that was controllable using basic measures, just hand washing, personal hygiene, quarantine, isolation. You didn't necessarily need a vaccine or therapeutics. Okay, so you can test all these conjectures public health people may have in times of epidemic, and then try to determine sensitivities to changes in parameter values of the model. So in other words, trying to determine what are the most important parameters that drive the disease transmission process. And I'm going to give an example later on in our model, in our COVID-19 model, to determine what are the main drivers of the COVID-19 pandemic in the United States during the time we did the model. We can also use modeling to compare, to plan, to implement, to evaluate and optimize various control strategies, like detection or prevention strategies. Okay, we can compare, for example, if you are a public health person and you have, let's say, $1 million to spend in trying to control the spread of a disease in your jurisdiction, let's say COVID, and the interventions available to you are isolation, quarantine, testing, and so on. What is the best use of your dollars? You have $1 million. Okay, how do you optimally use that to minimize cases, hospitalization, mortality, and so on? Okay, so that's what modeling can help you do. And you can also identify trends and make general forecasts. Okay, so the purpose of modeling is to design a model that represents the data that you already have, and then use it to make a forecast, a prediction of what is likely to happen in the future. And also early estimate of some important epidemiological thresholds, such as R0. Everybody has heard so much about R0. I'm going to describe this a little later, what it actually is. Okay, so, but based on all of this thing, you can see that the kind of work we do in mathematical epidemiology is inherently multidisciplinary. It's not something just a mathematician can do alone. You have to work with other people, public health people, clinicians, biologists, computer scientists, statisticians, ecologists, evolutionary biologists, pretty much everybody, including social scientists. During the time we were working on Ebola, I didn't realize I have to actually work with communications people, because it doesn't matter how great your strategy for control is, if you're not able to message it properly, if you're not able to create or to put it, if the messaging is not great, if you're not able to find an effective way to communicate your strategy to the general population, then your strategy is not going to get implemented properly. So you need to be able to sell it to the layperson, to someone who is not a scientist or who is not a modeler or mathematician to accept. So we have to work together. I mean, that's the era now for people working in silos is long gone. It's multidisciplinarity. We all have to work together. If you want to solve some of the world's most important problems, we cannot do so alone. We have to work together. So mathematicians are very actively working with other colleagues from other disciplines to address some of these questions, just like other scientists are working in collaborations with others as well. So anyway, the point is we have to work together. We cannot do so in isolation. Okay, but some of you may be surprised to learn that the framework for mathematical modeling was laid down not by mathematicians, but by public health people. And historically, mathematics has always been playing a major role in providing insight into the spread and control of diseases. But the framework for mathematical modeling was not done by us. It was done by mostly public health people and epidemiologists. And I'll give some examples. The very first model built, I think, was by Daniel Bernoulli to try to understand, using modeling, the impact of immunization against smallpox. And smallpox is one of two diseases we have managed. It's one of two vaccine preventable diseases we have managed to eradicate. Okay, so the second one being rinderpest, okay, disease in cattle. We close to eradicating another one, polio. I think the Gates Foundation has been doing amazing work trying to help eradicate polio globally. Okay, so anyway, so Daniel Bernoulli's model was the first one. And then there's a series of other pioneering models, I would say, by Sarona Rose, who I'll talk about later on. He was the first to give the full life cycle of the malaria parasite, Plasmodium, that causes malaria in humans. And later on, I'll talk also briefly about George MacDonald, who extended Sarona Rose's work. Sarona Rose's work was fundamental in the sense that his main conclusion, in addition to his medical work, he also designed the very first model for malaria. And he showed that we do not have to kill all mosquitoes in Western Europe to eliminate malaria in Western Europe. Just kill enough of the mosquitoes to bring the mosquito density or the population abundance of mosquitoes below a certain threshold, and that will be it. And that's what happened. Okay, so he laid the foundation for threshold in mathematical analysis. So that's the notion of reproduction number, R naught. R naught less than 1, we're good. It doesn't have to be 0, less than 1, you are generally good. Okay, so anyway, so William Kamek and McKendrick laid the foundation for actually how to do this. It is a compartmental modeling framework. You want to model the spread of disease, you split the population into mutually exclusive compartments based on disease status. So you have the S, susceptible, infected, I, recovered or removed, R. They did that and they wrote this amazing paper in the Proceedings of the Royal Society. Those are biochemists and epidemiologists. But every model we talk about right now, compartmental model, pretty much any modeling type you use, it's an extension or a special case, maybe, or maybe it's based on the foundation of the Kamek-McKendrick formulation. And this again was done by non-mathematicians, by chemists and epidemiologists, and so on. Okay, so in terms of disease outbreak, public health people have their wish list of things they want. So early estimation of reproduction number, for example. Okay, during COVID, the early stages, COVID hit in last December 31st. Within the next few weeks, everybody wanted to know what the reproduction number for the disease is. If it's high, greater than 1, then we know we're going to be dealing with a very serious problem. So many of the modeling groups estimated what R naught is using the initial data. Okay, it was about 3 to 5 at the beginning. So that's when everybody thought, wow, we're going to be dealing with a serious problem. It's not like the other coronaviruses, which had R naught led between 1 and 2 at the beginning. And that's what we have seen now, because the R naught was so high at the beginning, explosive number of cases, explosive growth, exponential growth. at the beginning, and that led to more hospitalizations and death, of course. So anyway, so public health people would like to have this early estimation of this quantity and also determine the qualitative nature of the spread of the disease and determine maybe an estimate of the expected burden of the disease, expected number of infections, how many people will be hospitalized, how many are likely to be in ICU. This is critical, the ICU admission number, because it tells the public health people how many ventilators, for example, they need to stockpile in order for them to meet the demand, and how many are expected to die and so on. And we can assess various control strategies and targeted strategies. For example, now we're talking about vaccine for COVID, but we will not have enough doses to go around at the beginning. So how do you optimally use the limited resources to achieve maximum impact in terms of reduction of number of cases, hospitalization, and mortality? Okay, so this is now R0. R0 is the average number of new cases generated by a typical infected individual introduced in a completely susceptible population. So let's say, okay, so red means someone who has a disease, okay? Blue means you don't have the disease, you're susceptible, but you're a target of the disease. You can get the infected, follow an effective contact with somebody who has a disease. So if R0 is 2, it means I'm the red here. This is the index case, okay? The index case. So you should think of this as COVID-19 in the United States. The first case was introduced in San Francisco area, January 20th of this year. So the first case, say, transmitted to 2 others. This one also, the second generation will transmit to 2 others. And before you know it, because nobody has prior immunity against this disease, nobody has been vaccinated, nobody has seen the disease before, we're all completely susceptible. Before you know it, everybody becomes red. But this is the best case scenario in the sense that some in the population have had prior immunity. Either it's a disease that we have seen, let's say the H1N1, okay, pandemic, during the H1N1 pandemic of 2009, the swine influenza pandemic, some people had immunity because we have seen H1N1 before. So they are yellow. Okay, so it's a nice mixture of some blue, some yellow, some red. Okay, and this is because to account for the fact that there's some kind of intervention that's going on. And this is now called effective reproduction number or control reproduction number. The C is for control, to show that you're applying some kind of control, either quarantine, isolation, vaccination, or some people just had the disease before. Therefore, they are less susceptible than those who didn't have the disease before. Okay, so, and this R0, the 0 in R0 is to show that the infected individual, in this case, is introduced in a completely susceptible population. Okay, no public health intervention whatsoever, and no one has prior immunity. So everyone is equally susceptible. You know, there's no differential susceptibility, but over here, you have some people are less susceptible than others. So that's what R0 is. And that's the most important quantity public health people want to see or want to have an estimate of in terms of epidemics of new diseases. If it's less than 1, then they know that the disease is likely going to die out. If it's greater than 1, but how large in relation to 1, that tells them the severity, the potential for the disease to be of severe burden to the community. So if R0 is 3, imagine within a short period of time, everybody in this population will get infected. All the blues will become red. Okay, so that's the idea. So R0 essentially is a measure of the exponential spread of the disease during the early stages. Okay, so R0 is 3. Imagine what each of the 3 T is time, and maybe some scaling constant. That would be explosive number, and I'll show you an example later on using data from New York. Okay, but we also, as mathematicians, we have our own wish list as well. So we want to study the models that we designed to try to extract the key features of the model qualitatively. And this is useful in determining what the R0 expression is and what conditions, under what conditions can we effectively control the disease, and under what conditions will the disease persist in the population. And we can also compute like herd immunity threshold. Everybody has heard a lot about herd immunity. So how do we calculate that using from our model? So to determine what is the minimum proportion of the people you need to vaccinate in order for those that cannot be vaccinated to be protected. That's the notion of herd immunity. But we also have some statistical interest. We want to fit the model with data to make sure the model makes sense, reproduces the data, or is a good representation of the data. And then that gives us justification to use it to make forecasts, because the proof of concept is to show that your model looks like the data. If it doesn't, then it's not a good model, right, essentially. Except, of course, if your data is not great. So, and we also have computational interest, so we want to be able to solve the model computationally. Sometimes the models are very large and nonlinear, therefore they're difficult to solve exactly in terms of analytical functions. So we have to use some numerical method to solve the models. Okay, there are many different types of models to use. Compartmental model, which is what I'm going to talk about, which splits the total population into mutually exclusive compartments based on disease status. It can be deterministic or stochastic. Stochastic is if randomness is incorporated into the modeling process, such as super spreading events, for example. And you can use spatial or patch models, meta-population model, or agent-based models if you know a lot of details at individual level, how the individual interacts with his or her environment, where each individual is an agent and so on. So you can use social network models as well, machine learning models, or statistical models to find correlations between quantities of interest. The type of model you choose depends on the questions you want to address, and also the data the quality of the data or the type of data you have. Okay, many of these models have their advantages and disadvantages. To determine which one is best for each problem is really open to the modeler. I mean, people have their preferences, what type of models they want to use and so on. But each has their own advantages and utility. I mean, one they are most suited. There are situations when you really should be using agent-based model and not compartmental model. And there are situations when you have to use meta-population model or statistical models and so on. Okay, so the simplest model, I'll just give, I think, 2 or 3 equations in the entire talk. And this is the basic model for the spread of infectious disease. So the total population N at time T is given by the sum of this population S, which is susceptible, which means those who have not gotten the disease, healthy people, but can get the disease later. And I of T are those who already have the disease and they are able to transmit the disease to other people. And R are those who have recovered from the disease or they are removed from the population. So the rate of change, this left-hand side here, the derivative of S with respect to time, the rate of change of the susceptible population is just governed by the infection. If the susceptible person interacts with someone in the I class, that's from probability transmission can take place, and this probability depends on how many contacts the susceptible person has had with the infected person. So once that happens, we have this minus sign which says, okay, you are no longer susceptible, because again, the 3 compartments are mutually exclusive. You cannot belong in 2 at the same time. So once you acquire the infection, we have this minus sign, then you become again in the I class. You move to the I class, and you're also ready for prime time. You're able to transmit the disease to the next susceptible person. And gamma is the rate at which someone in the I class can recover. So 1 over gamma is the recovery rate. Okay, so beta is the mean number of contacts someone makes per unit time, is what we call effective contact rate. Okay, so this is the Carmack-McKendrick model in 1927. This is basically it. All other compartmental models are basically based on this model, just extension of this basic model. And this model is based on so many assumptions. Of course, every other model, I mean, models are built based on some assumptions, okay? And the effectiveness of your model depends on the quality of the assumptions you make. So some of the assumptions made in the formulation of this model are closed population. Nobody comes in, nobody leaves, okay? So there's no birth death process, there's no immigration or migration into or out of the population. Okay, just simple situation. And once you have the disease, the duration of infectivity is actually the duration of the disease, which means once you got the disease, if you got the disease right now, you are instantaneously capable of passing it on to other people. But of course, in many other realistic situations, that's not the case. That's the incubation period. You have to survive the incubation period before you can transmit the infection. But for the simplest possible model, we have this assumption. And we also dealing with large population sizes, so that you can use it. The model is deterministic, so you don't have to incorporate random events. Okay, so since it's a large population size, even if they are super spreaders, they are not large compared to the total population. Therefore, their impact or their effect is not considered to be very significant. It's like the stock market. If you look at a stock market on a day-to-day basis, then you have to use stochastic model because of fluctuations you may have to. But if you look at it over a 1-year period, all those fluctuations basically even out with time, and you see that it's fairly constant throughout the year. So that's the general idea. Exponentially distributed waiting times in each compartment, and once you recover, you never get the infection again. So this is the simplest possible model, and we can compute the reproduction number of the model by basically saying, well, if I'm in I class, what is my ability to transmit to the infection to the susceptible person is beta times S initially, beta times S naught. And how long I'm able to do that is 1 over gamma. So if I multiply the 2, that's my R naught. R naught in principle means the infection rate times the average duration of infectiousness. Infection rate times how long I'm able to infect people. That's it. That's basically what R naught is my ability. If I'm infected, how many new people can I generate before I die or before I get cured of the disease? And the answer is simply, well, it's my transmission rate, the rate at which I'm able to successfully transmit the disease to another person, times how long I'm able to do that. That's it. That's R naught. So here is the transmission rate. My ability to transmit is beta times S naught, times 1 over gamma, which is how long I'm able to do that before I recover. So you see, if you're a public health person, you say, well, this is my R naught. Okay, and my objective is to reduce R naught to a value less than 1. How do I do that? How do I do that? Well, if I reduce beta, obviously, right? If I reduce beta, because beta is in the numerator, if I reduce beta, and how do I reduce beta? Beta is a contact rate parameter. How do I reduce beta? Beta is by reducing contacts, say quarantine, isolation, okay? So using face masks, okay? And so on, so that you're not having this effective contact with people. I'm keeping social distance, I'm keeping 6 feet away from people. So this is all buried in this parameter beta. And another thing you can do to reduce R naught is to increase gamma, this parameter. Well, this parameter is recovery rate. So increase the recovery rate of people. How do you do that? By treatment. Or maybe by the public health people in hospitals coming up with better ways to manage, to treat people, not necessarily using treatment, but maybe better using ventilators, using all those things that can enhance the recovery process. So again, the point is, but by doing just simple algebra, you can in fact determine what is the best strategy for controlling the spread of the disease. Because the best strategy is one that reduces R naught to a value less than 1. And therefore, the only things we can measure or we can control are beta and gamma. We cannot, S at 0 is the initial number of susceptible people at time 0, initial. So we cannot touch that. The United States, S at 0 is 330 million people. Okay, that's what it, anyway, so these 2 parameters, we can determine which one. And we can also determine which of the 2 parameters is most sensitive. What is the major driver of R naught? Which one, a small, let's say a 10% increase in beta leads to a much bigger increase in R naught compared to a corresponding 10% increase in gamma. So that's called sensitivity analysis. You can determine of the 2 parameters, which is the most important. Which one should we target the most? You know, a greater reduction in beta gives you much better use of your dollars compared to a corresponding increase in gamma or decrease in gamma. Anyway, if R naught is less than 1, the epidemic declines to 0. If it's greater than 1, the epidemic persists in the population. And this is the picture. So typically for SIR, we started, let's say, with 10,000 people, because the S class is a decreasing function, so number of people becoming susceptible goes down, and no more susceptible people because everybody got the disease and they have recovered from the disease. So, and that's basically what SIR shows you. And now I'll talk quickly about the Ross-McDonald model. And the reason I want to show this is to highlight the principle of what R naught is. So Ross in the 1920s came up with this model for malaria. Malaria is one of the most important infectious diseases. So X is the number of infected humans. Z is the number of infected mosquitoes. So just 2 equations. Malaria is transmitted by a bite of a female Anopheles mosquito that takes a blood meal from humans needed for the development and maturation of eggs. Okay, so if the infected mosquito bites a human, susceptible human, which is H minus X, okay, that's some probability that transmission can take place. And that probability also depends on this parameter M, which is the vector host ratio, number of mosquitoes per human. And R is the recovery rate of humans. And the same thing happens here also. The susceptible mosquitoes biting a human that already had the disease. Okay, this is the bite rate, and this is the probability of infection per bite. And this is the natural death of the mosquito. Okay, the reason this is important is for this simple model, okay, Sarono-Rose was able to calculate the reproduction number, which is given by this. And this parameter M in blue is what is critical. Again, it's in the numerator. Therefore, to control R naught, to bring R naught down, you just need to focus a lot on M. Reduce the mosquito host ratio, mosquito human ratio, number of mosquitoes per human. Okay, and that's what led Sarono-Rose to make the recommendation that, well, the best way to do this to achieve effective control of malaria in Western Europe or elimination of malaria in Western Europe, just focus on M. Habitat reduction, get rid of breeding habitats, or larviciding, basically, get rid of all this breeding habitats. And that was what was implemented at the time by WHO, this strategy, okay? And at the time, DDT was not invented, okay? It was invented in 1939, but that was the basis for malaria control globally at the time, particularly in Western Europe, based on this simple model. But then, okay, so in this model, Sarono-Rose assumed that once the mosquito becomes infected, that mosquito is instantaneously capable of transmitting Plasmodium to a human. But that's not true in general. The mosquito has to also survive the incubation period. Is what's called the sporogonic cycle. There's 4 main cycles associated with mosquito, right? Malaria. One is the aquatic stage, it's the eggs, larvae, pupae, adult mosquito. That's the first cycle. The second cycle is a gonotropic cycle. Once an adult mosquito pops out, it looks for a human to bite, take a blood meal, and then it goes through the gonotropic cycle, finding a resting place and also finding a breeding habitat after the eggs have developed and matured in the mosquito. So that's the gonotropic cycle. And there are 2 cycles, one in the human host, which is called the schizogonic cycle. So if we're infected with the parasite has to mature in us. Also, we have to go through the incubation period before we can transmit to the mosquito. And the same thing was in the mosquito as well, the sporogonic cycle. So that's what George MacDonald added, just this simple term in blue, that the probability that the infected mosquito survives the sporogonic cycle and become infectious. Everything else was the same as in the Ross model, okay? But then they are not changed by exactly the same factor, exponential of minus mu tau. Tau is the delay before the infected mosquito becomes infectious. And mu is the natural death rate of the mosquito, which is like 21 days. On average, mosquitoes live, adult mosquitoes, female mosquitoes live to be 21 days. And this changed the strategy, because what George MacDonald says, well, we now have to focus on get rid of these mosquitoes before they become infectious. Do not worry about aquatic mosquitoes. No, focus on adult mosquitoes, kill them while they are resting on the wall during the second stage of the gonotropic cycle, before they become infectious. Okay, even if they're infected before they become infectious, kill them at that. And that led to this idea of using insecticides to target adult mosquitoes in the form of bed nets, long-lasting insecticidal nets, IRS, indoor residual spraying, and so on. And then DDT was invented, of course, at the time, and it was widely used, particularly during the Second World War. But the mosquitoes become resistant to it. This strategy to eradicate malaria was disbanded by WHO in 1969. So that's the point I'm making. The simple model can be used to draw really compelling conclusions. Okay, and now for something completely different. Those of you who are familiar with Monty Python will be laughing, will be screaming at this stage. This is John Cleese. So I've talked about the background and the foundation and all that. So now I'm going to go into COVID-19. Okay, so Wuhan city public health officials informed the WHO of this new disease December 31st. I mean, there are arguments to say that this disease has already been around before that, but let's assume officially that it started December 31st. And we had our first case in the United States, the 20th of January of this year. And March 11th, WHO declared this to be a global pandemic. Okay, coronaviruses are everywhere in the wild. There are a group of RNA viruses, maybe about 1.5 million of them in the wild, which means we are constantly a mutation or two away from a spillover from animal population in the wild into domestic animals into humans. Okay, as long as we have this close proximity with those animals, we're going to be constantly prone to those kind of pandemics. Just like we had the H1N1 pandemic, which started out of pigs right here in the US or in Mexico, I think the 2009 swine influenza pandemic. So pandemics can start from pretty much anywhere, depending on what kind of mutation happens from which animals to the humans. So as of today, there's definitely no safe and effective vaccine for use in humans and antivirals for wide-scale use. There's great potential for 2 vaccines now by Moderna and also by Pfizer, with expected efficacy of greater than 90%. That's definitely something we all look forward to. And that's one of the reasons I included also vaccination in this presentation. So I'm going to talk briefly about it. But in the absence of these therapeutics, the only option we have for control of this disease is through basic non-pharmaceutical interventions, like community lockdowns, like face mask usage, like social physical distancing, like quarantine and isolation testing, contact tracing, and so on. So the usual thing. Today's lecture is going to focus on the use of face masks, and later on I'll talk briefly about vaccination. Okay, so 3 coronaviruses have appeared already on our landscape. We saw the SARS-CoV, the first one in 2002. out of Guangdong province of China, came out of bats and civet cats into a form that's transmissible between humans, spread to 29 countries, caused about 8,000 infections globally, and less than 800 people died. For the 9 months that it's been around, okay, it was spreading for 9 months. MERS started in 2012 out of Saudi Arabia and Jordan, also bats and camels, and caused about 2,600 infections, less than 900 people died. They had much higher case fatality ratios, but COVID-19 was a different beast altogether, okay? Within a few days, few weeks, spread to pretty much every country on planet Earth. As of today, we had more than 57 million cases, confirmed cases. Over 1.3 million people have already died globally. Even though its case fatality ratio is much smaller than its previous cousins, or its two other cousins, it's a lot more devastating than the others. Similar symptoms, but the main lessons we learned from SARS and MERS was those are two coronaviruses that were controllable using basic control measures. We didn't have to use vaccination against SARS or MERS. We didn't have to use major antiviral again. We just control those two, particularly SARS, because nobody currently has SARS-CoV on planet Earth, as far as I know. Was just basic thing, quarantine and isolation and hand washing, and we didn't even have to use face masks. I don't remember using face masks during the SARS. Anyway, but this is a different beast altogether. But the point is, the two previous coronaviruses were controlled using basic control measures. Well, MERS is still going on, but it's only restricted to a few countries in the Middle East. Okay, so it's not widely spreading. Besides, it only spread to 27 countries, not to the entire countries within the United Nations. Okay. Anyway, so and these are the numbers. Everybody is very familiar with all these numbers. This was the number of cases, 7-day averages. So we see the first wave, the second wave, and now we've seen the third wave in the United States. And also this is the mortality figures, okay, correspondingly. 11 million, about 12 million confirmed cases in the US, over 253,000 have already died in the United States. And this is figure from New York Times showing the 14-day average. I mean, as of November 18th, 77% increase in confirmed cases and 52% increase in mortality and so on. That's we are in the middle of, we've been hit with the third wave of the pandemic, or second wave, depending on where you live. Anyway, but why that's the case? See what's happening. This was from the Onion newspaper in Dallas. People were not observing social distancing, were not putting on face masks. This, my body, my choice, symbol of tyranny, all the things. But masks have been, okay, so again, the focus is mask usage. So, but masks have always been used in an attempt to control the spread of diseases. Some of you may remember this, this myth of the plague doctors in France and Italy, where the doctors were wearing this costume or this clothing with these beaks, which they marinate with some aromatics like lavender, like some roses and so on. The idea then was that this will dispel the smell, because it was considered during the plague that the smell was what was causing the disease, of course, until the germ theory of disease came along to dispel that rumor. And this cane was used, this was a wooden cane, was used for all sorts of purposes by the doctors to determine actually who, the areas that need attention, so they can pinpoint instead of touching with their own hands, they can pinpoint using the cane, and they can examine patients using the cane without having to touch them. They can keep people away using the cane, or they can remove the clothing of their patients without having to touch them, and they can also take the pulse and so on. Anyway, so the point is that masks have always been, of different types, have always been used going back to the plague of the 17th century. And also the Manchurian pneumonic plague, the same thing. So they're using this gas mask here, 1910, 1911. Surgical masks were invented in 1897, 1905. Again, doctors here wearing surgical masks. During the 1918 pandemic of influenza, also these gas masks were used. Not clear the origin of this disease, but the point is multiple waves, just like we've seen with COVID-19, 20 to 50 million people died, 1918 pandemic, 675,000 in the United States. But masks were used also of different qualities, of course, different from the type that we have. Okay, and the same, again, these are the doctors. If I fell, he died, so doctors were taking it very seriously. Everybody wanted their mask. Where a mask, this gas mask has like 99% effectiveness considered at the time. Of course, now we know better. They were effective, but not that effective. Very, very ineffective, actually. But now we have medical masks, okay, and these are particularly surgical mask and the N95 mask, which are the super duper masks, which can filter out about 95% of airborne particles, including large and small particles, as large as about 0.3 microns. Okay, so these are really the best ones that we have, the surgical mask and the N95 respirators. And you can compare them. This is a picture I got from the CDC website comparing the two types of masks. So because of time constraint, I'll quickly run through. Yeah, strong benefit using this kind of mask, different levels of efficacy. We can discuss this in some detail later on. Anyway, so the first model we built was to answer the simple question. This was during the time of the first resurgence of COVID after the first wave. And we're interested in what was happening at the time. The first wave, of course, hit New York State the hardest, okay, and then followed by other states. But then we have a resurgence in states like Florida, like Arizona, and so on. So we wanted to study whether or not the community-wide use of face masks could curtail or could minimize community transmission in those three states: New York, Arizona, Florida, and the entire United States. Okay, this was again this data we use a project we carried out sometimes in June. So we wrote a simple model or designed a simple model with susceptible class, exposed class, meaning those who got the infection but they are not yet infectious. So when we say exposed, mathematically means you already have the disease. It's not like you've been exposed to someone you're at risk of getting. No, you actually have it, but you are late and you are not. The viral load is not high enough for you to become sick, to become infectious. And then we have the pre-symptomatic stage, which means you are almost close to surviving the incubation period. But that we found later on that pre-symptomatic transmission is very critical also in COVID-19. People can transmit the infection while they're pre-symptomatic. And this is the infectious class of people who are asymptomatic. They are infectious, but they do not even know they have the disease. The same thing here, pre-symptomatic. You are transmitted, but you have no idea you have the disease. And IM, those are the ones that have symptoms, but the symptoms are mild, M for mild. IS are those with symptoms, but the symptoms are severe. II are those with symptoms, but they are in self-isolation. And IH are those that are hospitalized. And IC are those in the ICU class. And the R class are those that are recovered and tested, and RT are the ones that have been tested for antibodies to see whether they already have recovered. So have acquired the infection and recovered from it. The reason we did this was to test at the time, we were testing the Swedish experiment. The experiment was just this strategy for herd immunity, just allow as many people to get infected as possible. And then that's how you can control or protect the vulnerable in the population. Okay, so we added this just to test that. It turned out, of course, to be not very good a strategy, obviously. Anyway, so the model is this complicated. I'm not going to go into details of it. If you're interested, we can discuss it later, or I can send you a copy of the paper. But the equations are all in here, not really to talk about. The key point is that when we write the infection rate that for susceptible people, we adjusted for the fact that those in isolation or in hospital or in quarantine are not part of the actively mixing population. So that's some kind of efficacy that if you're in isolation, you're not going to be generating new infections at this rate, theta. Okay, if you're in hospital, you are less likely to transmit it. Of course, this was not true during the early stages of the epidemic because in healthcare settings, we're not fully aware of the best ways to prevent the healthcare workers from getting infected from their patients or by their patients. But around June, I think we knew all this. I mean, so this was almost unlikely for someone in hospital to transmit to the doctors and so on. Anyway, and this epsilon M is the efficacy of the mask, which is a number between 0 and 1, and CM is the compliance level of the mask usage in the community. So what proportion of the members of the community put on face masks consistently every time they go out in public? Okay, so this is a measure, this epsilon M times CM is a measure of mask preventability. the relative effectiveness of the mask to prevent you from passing the disease to others or from acquiring the disease from other people. Okay, so we started by fitting the model with data. This is for the state of Arizona, the first one. This is Florida, this is New York, D is the entire United States. This is for the pre-lockdown period, and this is, we fitted also for the lockdown period. Again, Arizona, Florida, New York, the whole of United States. So the reason we did this, again, is to show proof of concept, to show that the model can be used to make predictions because it matches the data reasonably well. This is for the period March the 6th until April the 1st in these locations. Anyway, so this is, until May, the lockdown period from March 31st till May 15th for Arizona, and till April 5th this is for Florida. New York was, it started early lockdown and stayed late. Actually, it was one of the last few states to lift their lockdown, which is May 28th. Everybody else has partially lifted before then. So New York really did a fantastic job in controlling the spread because of this point that I just made. Anyway, so we used the model to make predictions. And we also fitted the daily death data. That's the reason we fitted the model with cumulative mortality. And if someone wants to know, I can answer that during the Q&A. We didn't use the cumulative case data for a very obvious reason. We think the mortality data is a lot more reliable than the cumulative data. But we can discuss that during Q&A. Anyway, the first simulation we did was, okay, well, we have this model for the 4 jurisdictions. What is the impact of face mask on the reproduction number? Remember, the reproduction number is RC, average number of new cases generated by a typical infected individual introduced in a population where a proportion of the population CM wear face masks in average. So it's not R0, it's RC, it's a control reproduction number because we are applying some control, like face mask usage. So you see that if the efficacy is really high, like let's say 95%, if we're using the respirators, 95%, and we want to bring RC to a value less than 1, somewhere here, either yellow or green or blue, you know, we need coverage, let's say in Arizona, we need coverage of about 85% of the population, even with the super duper efficacy mask. You know, so it's going to be really difficult to use the mask alone to control the disease in Arizona. But in New York here, because of the great work done during the lockdown period, if we have a super effective mask, 95% effective, we're here, they only need about 40% or 30% compliance to eliminate the disease, to bring RC less than 1 and eliminate the disease. So we got these numbers. If we use enclosed mask, which has very low efficacy, over 25%, in Arizona, we need at least 75%, 76%. Sorry, this is for New York, 76% of New Yorkers have to wear a face mask. The compliance percentage has to be about at least 76%. For the entire United States, it has to be 92%. These are not attainable numbers to have 92% of the US population wearing face masks. So it's not a great idea to use this low efficacy face mask in places with high community transmission. And in fact, this low efficacy face mask have no chance of eliminating the disease in Arizona and Florida. At the time, Arizona and Florida were having really big rebound or resurgence of the disease. But if we use N95 respirators, you know, those again have efficacy of 95%. We require about 30 to 40% compliance. And this is very attainable to say 3 out of every 10 people will be wearing face masks in public. If everybody is wearing this kind of mask, N95, and they're very cheap, actually, they're less than $1 now per unit. If we're wearing N95 respirators, 30 to 40% of us are doing so, we're going to effectively control the spread of the disease using just mask alone, nothing else. But then imagine you compare this, you combine this with social distancing. Okay, I mean we can do this. But this is what this plot show. Using high efficacy mask with moderate levels of compliance, we can bring the reproduction number to a value less than 1, and we have a great chance of eliminating the disease, even without a vaccination, without vaccine. Anyway, so the first question we wanted to address after the efficacy comparison is, who are the main drivers of the epidemic? Remember, when I showed the force of infection, there are 4 classes of people who can transmit the disease. The pre-symptomatic EP, the asymptomatic, the symptomatic with mild symptoms, IM, and the symptomatic with severe symptoms. All of them are transmitted, but who among those four classes, which among those four classes is or are the main drivers of the epidemic? In other words, who are responsible for most of the infections in the United States? So what we did was to fit the model with the data for the United States and the three states, Florida, Arizona, and New York, and use the data to estimate these parameters, beta P, beta A, beta M, which is the contact rate associated with each of these classes of infectious people. Okay, and the numbers tell us who the main drivers are. And immediately we saw that the pre-symptomatic and asymptomatic people, the sum of these two, account for example, during the pre-lockdown in Arizona, about 65% of all the cases, all the new cases. In Florida, it was 72%, much higher in New York, much lower in the entire United States. And during the lockdown period, we have what this shows, this simple simulation shows what the main drivers of the epidemic are people who do not even know they have the disease. And the only way to track them is through random testing, right? This shows clearly that one of the most effective things we can do to control the spread of the disease is massive, large-scale testing, and not just testing of those with symptoms, as the CDC was emphasizing, and is still emphasizing, you only test those with symptoms. No, we test everybody, and that's the only way we can detect those who are asymptomatic and pre-symptomatic. And then you trace them, trace their contact, and then you isolate them. Okay, this immediately shows that yes, we have to, and that's the strategy we have to use. And we still, unfortunately, we're still not doing random large-scale testing, and we still have to do that because there are a chunk of people who are busy transmitting the disease unknowingly. It's still the same today because we're not doing random testing. Okay, and then we asked the question, what is the impact of early lockdown on the pandemic? Okay, if we started early, so before I do that, okay, so Arizona started lockdown, the lockdown was on March 31st, and we lifted lockdown on May 15th. Governor Ducey announced partial lifting on May 15th, okay? And Florida started April 3rd and basically partially lifted May 4th. New York started March 22nd, stayed on lockdown until May 28th, did much better than pretty much every other state in the United States. Much better because they were first to start lockdown and they were last to partially lift it. So they've been able to massively control community transmission by keeping people in lockdown for extended period of time. And for the entire United States, we just did some estimates. We think that, let's say, the entire country started April 7th and they partially lifted when New York partially lifted. So that's anyway, so, and during the week before New York started its lockdown, the week before March 22nd, the number of cases, total number of cases in New York was 740. And only 10 people have died in New York at the time, as of March 22nd. Sorry, at the previous week, the week before March 22nd. Now, a week later, see the number of cases. It skyrocketed from 740 to 15,885. And the number of deaths from 10 to 740. So that clearly shows the measure of the exponential spread of the disease. Just 1 week delay is equivalent to a massive burden of the disease, causing a lot more cases and mortality. So the question we ask is, suppose we started lockdown a week earlier or 2 weeks earlier in New York, in Florida, in Arizona, and the entire United States. And that's in green here if we started two weeks earlier, and magenta is we started a week earlier, and blue is when we started the time we started. So this green here is the duration of the lockdown for Arizona, Florida, New York, US. And you can see clearly, this was the actual observed trajectory. This is the data, the red dots are the data. So you see that we have this huge number of cases in Arizona and coming down. But if we started a week earlier, if we started lockdown a week earlier, this is the magenta. This is what we would have observed right here. And if we started 2 weeks earlier, we basically would probably not even have a resurgence of the disease if we started lockdown 2 weeks earlier. And the same thing for pretty much Arizona, Florida, New York, and the entire United States. So early implementation of control measures is well known in public health and is still true today. Hit hard and hit early. That's a great strategy. If we started, we cannot afford for a disease with high R naught, we cannot afford to be a week or 2 weeks behind. And we've been behind right from the beginning. If we started lockdown a week earlier or 2 weeks earlier, we would have had a very different trajectory of the disease in all 4 jurisdictions. That's what this simulation showed. And also, what happened if you use masks during lockdown? Again, so during lockdown, these are the estimates of the proportions of people that were using face masks. In Arizona, was only 14 to 17%, based on what the data showed us. In Florida, was 16 to 21%. New York was 15 to 21%, and in the entire US was less than 23%. Well, so suppose we had a lot more people wearing face masks during lockdown. Again, the trajectory of the disease would have been very different. A lot lower cases if we were wearing face masks. So the details on the paper in here. Okay, so quickly I'll talk about vaccination, because now is the topic, everybody is talking about vaccination. So we designed a simple model to ask the question, can a good vaccine in the United States help control the spread of the epidemic or eliminate the disease in the United States? Okay, so we fitted the model again. It was data. This is from March till June. The fitting was reasonably good, so we used the model to make predictions. We calculated the herd immunity threshold, which is given by this quantity. And we assume at the time in June, everybody, including Anthony Fauci, was saying, well, the vaccine, if we got a vaccine, would be, the efficacy was not going to be more than 70%. So we're very pleasantly surprised that Moderna and Pfizer announced their efficacy estimate to be in the neighborhood of 90 to 95%. That's really super impressive, so we're all very delighted. But anyway, using estimate of 70% efficacy of the vaccine, we calculated what is the impact of that? What will be the level of herd immunity? I mentioned what herd immunity means. Some people cannot be vaccinated, right? Because of so many different reasons. Maybe they are infants, they're just kids that are born, or people have underlying conditions, other medical conditions, such that vaccinating them makes it worse for them, and so on. And some people may opt out of vaccination for traditional reasons, religious reasons, and so on. So there are a certain proportion of the people that we cannot vaccinate. So the question then is, of the proportion that we can vaccinate, let's say 80% we can vaccinate them. Okay, so what is the proportion, what the minimum proportion of that 80% we can vaccinate, so that the 20% we cannot can be protected, can benefit from the immunity you built in the community? That's the idea of herd immunity. And there are 2 main ways to do herd immunity, to achieve herd immunity, right? Like the Swedish have tried. The first one is, okay, just allow as many people to get infected, and that's it. If you are infected, then there's some immunity against future infections, and that's how you build herd immunity. That's what has been proven to be extremely dangerous, because look at the cases for COVID in Sweden compared to its neighbors in Denmark, in Norway, and so on, other Scandinavian countries. You see a totally different trajectory, totally different number of cases and mortality, way worse in Sweden compared to the others. Okay, so, and the second way to achieve herd immunity is through vaccination. This is the fastest and the most effective way to achieve, and the safest way to achieve herd immunity. It's through immunization, but we cannot vaccinate everybody for so many different reasons, as I mentioned. So what we showed from our simulation is, if nobody uses face masks, okay, and this was again based on the data as of June. Now we have to revise this to its current data. Things will change because now we have a lot more cases. So this was June, July. If we have a vaccine that's 70% effective, we need at least 85% of the US population to be vaccinated to achieve herd immunity. But if 10% use face masks, okay, this level of herd immunity reduces to 83%. If all of us use face masks, we only need to vaccinate about 46%. Vaccinating 85% may not be easy, may not be attainable, because there's already, the whole notion of vaccination has been politicized now, and it's going to be very difficult to achieve high coverage of like 85% and so on. So even though we have a great vaccine, well, we're going to have a great vaccine or collection of vaccines, it's not going to be the magic bullet. It's not going to solve the problem. I think it has to be combined with some non-pharmaceutical interventions, particularly face mask usage, and not at the same level that we are advocating right now to say we have to have a lot of people wearing face masks. But I think vaccine that's 95% effective, combined with some face mask usage until we bring out not less than 1, will be the way to go, and still some social distancing. Anyway, but this was based again on efficacy of 70%. If we put in 90%, 95%, then these numbers will change. We may have reasonably more attainable coverage levels. Yeah, so here you can see how the reproduction number is changing with coverage and efficacy. So if the efficacy is 95%, for example, somewhere here, so to achieve RC less than 1, we need about 80% of the people to be vaccinated. And it's not practicable to vaccinate about 80% of the population. So but if you combine that with face mask usage, you see that you reduce the proportion. Anyway, so conclusion, early implementation of effective strategies, always good. Hit hard, hit early is also a good thing. If you combine public mass use strategy, using this strategy can actually lead to elimination. Even more so if we use the super duper N95 respirators, we only need 30 to 40% of the US population to wear that to achieve elimination. Adopting this strategy can help about future lockdowns. Using this face mask, we may not have to lock down. Otherwise, with this increase in skyrocketing community transmission, unfortunately, we may have to seriously consider stay-at-home restriction, except if we are all going to be wearing, or not all, but many of us will be wearing high-quality masks, like at least 30 to 40% of us. Just recently, I think just a day or two, yesterday actually, the WHO issued out this, lockdowns could be avoided if 95% of the people wear face masks. We say even lower than that, 30 to 40% if we wearing, but this is based on wearing cloth masks and other low-quality masks. But if we're getting the N95 respirators, if we can get this widely available to people. I know at the beginning it said these respirators were meant for public health people, medical people, and so on, but now they are widely available. They're everywhere now in Lowe's and in Home Depot and so on. You can order them online. They're available. It's just like $1 or something per unit. If we can get 30 to 40%, we can actually avoid lockdown. Otherwise, we have to seriously consider lockdowns, unfortunately. Yeah, so random testing is critical. It's very crucial to detect, as I mentioned, those asymptomatic and pre-symptomatic people. Unless we do that, we're always going to be behind the epidemic because we have no idea who's doing the transmitting. This asymptomatic, pre-symptomatic are usually younger people. They get the infection, they don't suffer severe disease. They are less likely to be hospitalized. They are less likely to die. So we may not know about them, but they are busy transmitting to their parents, to their grandparents, to people in the mall and so on. They are the reservoir of the disease, those pre-symptomatic and asymptomatic people. Until we do random testing, we'll not detect them, and we'll always be behind. Okay. Yeah, herd immunity can be achieved. Yeah, but then there's a big picture. In conclusion, yes, I mentioned all this. We can achieve effective control of the disease, COVID-19, using non-pharmaceutical interventions. If we do get a vaccine, it is not going to be a magic bullet, but we may have to combine it with some non-pharmaceutical intervention. So again, like the previous coronaviruses, SARS and MERS, COVID-19 is also controllable using basic public health measures. This we have shown, not just us, other groups have shown that too. We can do so even without a vaccination. Of course, using vaccination makes it a lot easier to eliminate, to eradicate it. But even without it, we can, but we have to make some sacrifices. We have to wear a mask for some time and also use high quality masks and also maintain social distancing for some period of time until we bring and maintain R0 to value less than 1. But we have to look at the big picture because these things are always a stopgap kind of, they're temporary measures to use these non-pharmaceutical interventions. Look at the examples I gave at the beginning, the plague, the 1918 pandemic, flu pandemic, the SARS, and COVID-19. They're all zoonoses. They are diseases that spilled over from animal population to human population, from domestic animals, from wild animals. Okay, so we're going to be having all of this unless we figure out how to deal with environmental diseases. This thing will be happening all the time. Okay, they are all related to human encroachment on wildlife, on animal farming. So, and also we're going to have future loss of habitat plus climate change, okay, makes us more vulnerable populations. So many other diseases such as malaria are also related to environment. Malaria, as I mentioned, is very much dependent on anthropogenic actions, of humans, like climate change, agriculture. Okay, we have to clear the land for agricultural purposes, for industrialization and so on. Migration, even bed nets. Bed nets are used. That's what really resulted in a massive decline in malaria cases from 2000 to 2015 by the Gates Foundation donating these high quality bed nets that were used in sub-Saharan Africa and Southeast Asia. But the problem is the mosquitoes have become resistant now to all 5 chemicals used in this long-lasting insecticidal nets. Okay, so, and the distribution of bed nets is now also affected by coronavirus. because you can't do so. It's not logistically feasible now to have more contacts with people. Again, until we pay attention to environmental diseases, figure out a lasting solution to that, we're going to be having these problems all the time. The face mask and the non-pharmaceutical interventions only provide a stopgap until all the underlying drivers of environmental diseases, such as deforestation, wildlife trade, concentrated animal farming, and climate change are effectively dealt with. History will continue to repeat. I'm sorry I've taken too much time, but I'll stop here and I'll be very happy to answer questions.
Thanks very much, Abba. That was a fantastic presentation.
Thank you.
I wish I could reflect all the applause that are probably going on in people's rooms across the country. But for now, it sounds like people are keen to stick around. For those of you that have to go, who are students to other classes, of course, feel free to go. But I think we have time for a couple of questions from the audience.
Sure.
Generally, the students field these questions.
I think the students are
Okay.
I think it's us.
Is it us? Okay.
Yes.
Well, why don't we ask some of the key questions, Andy, and start with one from you, and then I'll follow up.
Okay, so this is from Tal Levy, who's also an instructor in the course. Why did it take so long for the CDC to say that masks benefit the wearer and not just reduce transmission to others if the wearer is infected?
Yeah, exactly. It's just last week, right? They made the announcement. It's definitely political. Masks have two efficacies: the inward efficacy and outward efficacy. I mean, if I'm infected, I'm wearing a mask. It prevents me from passing on to susceptible person who is standing within 6 feet of me. I mean, that's clear. But for political reasons, and an inward efficacy is, if I'm not susceptible, I wear this mask, particularly the N95 respirators. Then the particles, the droplets, and will not get in, so it will not transmit infection. To me, it's well known. It's just surprising that the CDC did not acknowledge this until last week. That could have.
I guess I don't.
Sorry, go ahead.
Well, I guess I would follow up. I wonder if it would have been more effective if the original message had been, "This protects you."
Absolutely. Oh, the messaging, yes. That's another thing I made at the beginning. So messaging is key. When I said during Ebola, I had to work with social scientists because that was really, I mean, you may have a great strategy, but the way you just stated, putting on a mask protects you. You're not just protecting, but protects you. That would have, in the same messaging when the vaccine manufacturing company that manufactured the vaccine against human papillomavirus, Gardasil, right? Mark invented that. It was marketed as a disease, as a vaccine against sexually transmitted disease. Wrong strategy. If you had, so human papillomavirus is a causative agent of cervical cancer and many other cancers. If it was marketed as a vaccine against cancer, I'm sure the coverage would have been much higher. And this also, it has efficacy of like 95%. If we have more people in the United States, like 70% of, typically is given to girls between 9 and 12, ages 9 to 12, young girls. If we can achieve coverage of 70% with this vaccine, we will wipe out human papillomavirus, which means we wipe out possibly cervical cancer. But the coverage level is still very low because, again, parents are told that, well, this vaccine is against sexual transmission. So messaging is extremely important. I think those of us, the natural and engineering sciences, I mean, we really, really have to pay attention to how we message our results to the public. It's extremely critical. This should be in our curriculum. We should insist that our students are taught how to message scientific ideas and results. That's a great question.
Yeah, we had that exact discussion actually on Wednesday about your paper.
Oh, good.
So one of the students in the class asks whether you've had any challenges communicating uncertainty around some of the parameters in your models and how you—
Excellent.
Yeah.
Excellent question. That is true. Yes. So the model has so many parameters, and some of the parameters, actually quite a number of the parameters we know from epidemiological data, from historical data. Okay, so so many we know, but the ones that we do not know for sure, we fitted the model with the data to obtain the best, and that's why we do the fitting. The idea of fitting is to obtain the best values of the parameters that you do not know, so that the model and the data are nearly identical or are reasonably close to each other. So that's a great question, but there are ways we also account for uncertainties in the estimates of the parameters. Of course, let's say beta, effective contact rate. How do we measure that? We measure that based on one person measuring contact rate, another person may come up with different numbers, 0.5, 0.55, for example, two different people. So how do we account for that? We define each parameter as a distribution, and then we use some statistical methods, like we do sampling for each parameter. It's called Latin hypercube sampling approach. And instead of just using one value of that parameter, we sample out 1,000 for each one, and then we take the average of all those. So there are some established statistical techniques to account for uncertainty in the estimate. That gives more validation to your work. And also, you also have to say that this is all within, you always have to give caveat when you do your modeling. You say the caveat is 95% confidence interval and so on, and subject to uncertainty and sensitivity. But we account for uncertainties based on using the statistical method. And also there's a related issue of identifiability to make sure that the method the model is identifiable, which means you can actually do the fitting correctly. So it's a coming together of mathematics and statistics together. You cannot do this model alone without also having this statistical background and knowledge. That's so important. Again, this is multidisciplinary. We have to, so we encourage our students to learn, students in ecology, students in mathematics, whatever it is, everybody has to learn a lot of statistics because that's so critical. If you do modeling, it doesn't matter what model you're doing, you have to account for uncertainties and also sensitivities, because there are many parameters. Which are the parameters that are most important in driving the R naught, for example? So if there are 20 parameters, which are the top 5 that really affect so if you do the sensitivity and if you do the uncertainty analysis and sensitivity, you may determine that maybe of the 20, maybe only 5 or 10 are really important. The rest have very low correlations. We use what is called partial rank correlation coefficients to correlate, to rank each parameter with respect to the other, if all the others are fixed. Then you give the ranking, relative ranking of each one. The ones that are highly correlated, either negative or positive, which is 0 and 1, those are the most important parameters. The others can be ignored. In fact, we use that sometimes for model reduction. If you have 20 parameters, only 5 are highly correlated, the other 15 are very low, have low correlation. You can ignore them. It shows that they are surplus to requirement, they are not needed. So you can reduce the dimensionality of your model, you can make your model even easier. So people in computer science use that in dimensionality reduction. All of this is together. The ideas from computer science, from statistics, from ecology, evolutionary biology, from everywhere, all coming together in one thing. But it's a great question. I like that question.
Yeah, I think actually, Abba, that's the perfect way to end the lecture on an interdisciplinary note. So thanks very much for your answers. And I think generally we sit around and chat for a little bit afterwards. So if anyone is really interested in hearing more discussion, that they're welcome to do that. But at this point, we'll consider the lecture finished. So thank you.
Well, thank you so much. Thank you so much for the questions. Thank you so much for inviting me. I enjoyed it. But I'll hang around if anybody has any additional questions or comments.
Super. Are you on your way to give a presentation to the National Academies, or is that something that just recently passed?
The what? National Academy?
Yeah.
No, I'm giving the Einstein lecture but that's next year for the American Mathematical Society. Okay.
Yeah, excellent.
Yeah.
Well, congratulations on that.
Well, thank you.
I'll ask one selfish question. I mean, you've introduced a little bit about how you might deploy the vaccine, or at least to what proportion of the population you'd want to deploy the vaccine, given various coverage and face masks, et cetera, and efficacy of the vaccine. I wondered if you've gone beyond that to think about who, and then spatially where the vaccine could be deployed to greatest effect.
That's a very good question. Who and where? So the who, I think, should be the most vulnerable, first of all. So of course, healthcare workers, frontline healthcare workers, and then the most vulnerable. So the elderly, people who have other underlying conditions, and also people who work in, let's say, meat factory workers, law enforcement people, people who work in retail stores, because they have a lot of contact with the public. So those are what I would consider the most vulnerable. Not the younger people. I would say that, and especially I have not thought about whether spatial heterogeneity needs to be incorporated. For now, I think since they're saying they were going to have like 50 million doses, this is, I don't know whether it's cumulative combined from the two vaccine manufacturers or just one. Pfizer is able to produce 50 million straight away by end of the year. Then that probably means you have to protect first. Of course, my selfish interest, you should first, I tell my students, you should always protect the mathematicians first. That's the key thing, because we're the ones who do the modeling. We're the ones who, I mean, it's true. Yeah. No, seriously, every time you see Anthony Fauci at the White House briefing, and they're talking about models that were developed by our colleagues in Washington State and Harvard and other. Yes, so without mathematicians, we have no idea what's going on. So the first set of people to be vaccinated are all the mathematicians in the United States, okay? And then you followed by the frontline health. No, but we have to protect the frontline, because those are definitely top priority, regardless of whether they have underlying conditions or not. We want to make sure those who protect us are also protected. I mean, that's key. And then definitely after that, those whose underlying conditions. Okay, those
I
definitely.
thought you were going to say the ecologists were next. But
ecologists too. Oh yeah. Well, when I say mathematicians, ecologists, we are the same, right? We have to understand. We have to do the. So ecologists, I like what you guys do, because it's consistent with the idea of epidemic intelligence. We need to know what's going on in the animal. I forgot to highlight that. And it's part of the environmental. We need to pay a lot of attention to what's going on in animal populations, because that's the key thing. That's when we can predict the probability of likelihood of a pandemic, of spillover. So the CDC has a unit called Epidemic Intelligence Unit. I didn't know that until recently, and that's great, because these are people who pay attention to going into the forest and all that, trying to figure out what's happening in the animal population. If they see lots of bats that are infected with some coronavirus, then they should start paying attention. Okay, well, there's possibility of a spillover from these birds to maybe some other intermediate host, and then to humans. So we can be prepared ahead of time. So we have the masks available, we have the vaccine available. That's extremely important. So ecologists should be scared. Yes.
The bat researchers out of all the ecologists should probably be on the top of the list.
Absolutely. No, I agree. I think mathematicians and bat researchers, yes. No, because the bats are responsible for most of the coronaviruses, right? I mean, so we are the top two to be protected. I agree. Yes.
So I think there might be some of the grad students from the class waiting to meet with you informally afterwards. So at this point, I think I'll leave it. I'm not sure if Nico set up an additional Zoom link for that meeting, but
okay.
I think he should have. So be prepared for that.
I'm not. Well, he had some other prior commitment. Unless he's Nico, I don't think you're still on, but you're still showing up.
Okay. Well, in that case, I think we can probably stop.
But yeah, we can stop. Thanks again.
Thanks
again.
Hey,
no problem. Thank you.